Hey, how's it going, everybody? This is Timothy Gentry, staff paramedic at Cooper University Hospital EMS. Tuning in here for the third and final bit of our pharmacology review. I want to tackle all of the other medications that I compiled into the all others section on my list that you've seen in previous shows. But if you're watching these out of order, because it is YouTube, and I have them labeled part 1, 2, and 3, but if you're watching them out of order, I just wanted to quick refresh some of the objectives. I want you to obviously learn the names of the drugs, generic and brand, because you'll see them interchangeably used a lot. But I want you to learn the names of the drugs that we specifically carry on the ground at Cooper University Hospital EMS. And I want you to have a rough understanding of what their concentrations and doses are and clinical situations where we're going to be using these drugs. I want you to, at a basic level, at the least a basic level, understand pharmacokinetics and pharmacodynamics. You'll obviously move on to a more advanced level, or you may have already learned it depending on where you're at in your training. But I also want to reiterate and refresh pharmacology, anatomy, maybe some biochemical concepts that you've previously learned or you just never got around to. So understanding things conceptually will be really important rather than just information regurgitation. And some assumptions that are worth mentioning is that obviously each EMS system has varying drugs, varying state protocols, and they're all kind of set by medical directors and other people. So just make sure you know your specific state or your national protocols and what their standards are. And the pharmacokinetics and codynamic information that I provide in the following slides typically only pertains to the IV route of administration, unless it's something like aspirin or something PO or, that is only given IM in the pre-hospital environment. But I don't expect you to pay attention to the onset and duration times so much. You can refresh them later. I'm not going to read them out loud. But obviously, there are other routes of administration for a majority of these drugs that I'm going to review. And these are just broad applications for the pre-hospital, the EMS environment. Doctors, nurses, combat medics, wherever you're at, you're going to have wider applicability of the medications that I'm listing, and you can use them for different things. But what I'm going to review on this slideshow is just kind of broad applications for what we do in the pre-hospital environment, especially here in Camden City, New Jersey. So moving on, just a quick about me to refresh. Should you want to, review my background, there it is for you. I'm finishing up school next year at University of Pennsylvania. And here are the drugs you can see in the All Others section. This is what we're going to be tackling today. It looks like a lot, but truth be told, it should be a somewhat simple review, and they're all useful and important medications to know about. Moving on, we have our first drug on the list, and that is albuterol. Everybody in their adult life at one point or one time or another has heard of albuterol. You know an asthmatic, you've seen an asthmatic, you've seen rescue inhalers, you've seen albuterol, you've seen nebulizers. Whatever it is, you're probably somewhat familiar with albuterol itself. So what we use this for is bronchospasm, wheezing, dyspnea, but they're all symptoms of an asthmatic. The hallmark of asthmatics is that bronchospasm and mucus production. So the way that it works is that it produces bronchodilation from relaxation of the bronchial smooth muscles, which relieves bronchospasm and reduces that airway resistance, right? So it's going to selectively stimulate your beta-adrenergic receptors of the lungs. Think beta-1 versus beta-2 receptors. You have beta-1 for, think one heart, beta-2, two lungs. So we're looking to selectively stimulate the beta-2 receptors. Just be wary of the side and adverse effects. You may hear if you administer, you have them on a continuous nebulizer, you may hear them complain of, palpitations. And you also want to be cognizant of the fact that it can cause hypokalemia in large doses, which obviously can lead to life-threatening arrhythmias and other issues down the road. Quick note worth mentioning. I know this looks like a lot. This is a real, complex biochemical pathway over here. You don't have to look at it in detail, but I just wanted to review the beta 1 versus beta 2 receptors because you're going to hear them referenced a lot. So it's good to have at least a basic understanding of what's going on. I know I previously mentioned a quick and dirty way of remembering is beta 1, one heart, beta 2, two lungs. But, that's not all encompassing. That's not true in every case. But the beta receptors, they're a part of the autonomic nervous system, right? So that's your sympathetic adrenergic receptors. Think fight or flight. On the flip side, you've heard of your parasympathetic, which some people may call your feed or breed receptors. And those ones, rather than beta and alpha, are going to be your nicotinic versus muscarinic receptors. So what we're looking at here is your beta receptors, right? Beta 1, beta 2. Beta 1 receptors are in the heart, and they're located in the heart, and when you stimulate them, you're going to bump up the heart rate and you're going to bump up the contractility, right? That's the goal. Whereas beta 2 receptors located in the bronchioles of the lungs and also the arteries of the skeletal muscles are going to, increase the diameter of the bronchioles to let more air in and out, which is really important when you have those sick asthmatics or the people who are real dyspneic. And they can also dilate the vessels of the skeletal muscles so they can receive increased blood flow, which then on the flip side is going to produce or is produced by stimulating the alpha and beta 1 receptors. But something to take away from that is also that the alpha receptors are important, and I know they're not listed on this slide, but it's worth mentioning that they're, the alpha receptors are located in the arteries. And, when it's stimulated, when the alpha receptors are stimulated by something like epinephrine or norepinephrine, the arteries are they're going to constrict. So it's just worth mentioning, right? Because we're going to talk about stimulating beta 2 receptors and whatnot when it comes to medications like albuterol and so forth. So I just wanted to make a quick note of that. Moving on, we have dextrose. So at our particular system, we carry dextrose 10%, or you might hear it referenced as D10. It's a hypertonic solution or a carbohydrate, and it's familiar to anybody, even if you don't work in medicine, right? Because it's the name of a simple sugar. It's made from corn, and I believe it actually is chemically identical to glucose, which you are obviously familiar with because that's your blood sugar, some people might call it. We use it for the treatment of hypoglycemia, right? More often than not, when the hypoglycemic is unresponsive, unable to follow commands, and you can't instruct them to eat complex carbohydrates or eat that oral glucose, you need to go ahead and push forward with peripheral IV access, and administration of D10. So while the increase in blood glucose levels occur, dextrose may decrease body protein and nitrogen losses and then promote the glycogen deposition. So one note is in the side and adverse effects, you need to be very careful of extravasation, right? Because this can really cause tissue necrosis. You want to avoid that rapid administration. You want this to be, as they're administered or as we carry them in our system, you want them to be a nice slow drip, right? We carry them in a drip. And you also want to be careful of hyperglycemia, right? And also worth mentioning, these are all worth mentioning, but it's also worth mentioning, you see a lot of this with the rapid, or not even rapid, just the push of D50 concentration. You'll see more often than not some hypoglycemia from that rebound hyperinsulinemia. So again, just, be cautious, be judicious when you're administering that D10. Diphenhydramine, more commonly known as Benadryl. Anybody that's been to a Rite Aid or a CVS knows what Benadryl is, anybody with allergies. But in our particular situation, what we're using this as is an antihistamine, right? It's important to know what histamines are, even at a basic level. I'll do my best to explain it, but they're essentially histamines are involved in your local immune response, right? So they're involved in your local immune response as well as regulating physiological functions in your gut, and they're also a neurotransmitter for your brain, your spinal cord, your uterus, etc. But so as a part of an immune response to foreign pathogens, the histamine is going to increase the permeability of the capillaries. So the white blood cells and some proteins can engage those pathogens in whatever the infected tissues are. So histamines are super important. But what this does as an antihistamine is it blocks certain effects of histamine. So it's an inverse agonist to the H1 receptors. So inflammatory response, mediator of itching, vasodilation, etc. And when you're administering this, more often than not, you'll see the patient get drowsy, sleepy, etc. So useful drug. You'll see it used for allergic reactions, anaphylaxis, etc. So you're not just giving it for symptom relief. You also want the antihistamine properties, the inverse agonist to those H1 receptors. Moving on, ipratropium bromide, really useful. You'll also hear it called Atrovent, and you'll see it administered in a duo-neb fashion, meaning there are prepackaged, pre-made albuterol and Atrovent, or albuterol and ipratropium bromide duonebs, which are administered in a nebulizer. And it's important to know why they're both useful, right? So you're looking for the stimulation of those beta-2 adrenergic receptors with albuterol, whereas this, we're looking to get that broncholytic action by reducing cholinergic influence on the bronchial musculature, right? So it's blocking muscarinic acetylcholine receptors. Think back to those parasympathetic, and essentially it's going to cause the smooth muscles to relax. So that's important. You're hitting it from two angles, right? So you're getting you're stimulating your beta-2 adrenergic receptors, as well as blocking the muscarinic acetylcholine receptors when you give this ipratropium bromide in combination with the albuterol. So you might think to yourself, well, why don't I just give one or the other? This isn't recommended, or it's not a preferred agent for administration by itself, just because it does have such an delayed onset of action, right? You look and it's greater than 15 minutes. If somebody's truly dyspneic, or there's a sick asthmatic, COPD, or whatever it may be, you don't want to wait. You don't want that delayed onset of action. Side and adverse effects comparable to that of albuterol, but again, it's important to understand that there's different mechanisms at play with this ipratropium versus your albuterol. We are plugging right through here. We are already to furosemide, which is also called Lasix. Not administered often in the emergent setting, at least pre-hospitably. You'll see it used in hospitals a lot. Maybe you'll see it used in a clinic a lot, whatever it may be. A lot of people also have a prescription for it for their home and daily use. So what we're using it for in the pre-hospital environment is heart failure patients. You might hear them referred to as CHFers, congestive heart failure, with fluid overload. And how it's going to work is it's going to inhibit the sodium and chloride reabsorption in the proximal part of the ascending loop of Henle. That's why it's called a loop diuretic, right? So it's going to promote the excretion of sodium, water, chloride, potassium, and it can also act as an antihypertensive. And so how it works as an antihypertensive is complicated, but it's also not. It's you're getting renal and peripheral vasodilation and a temporary increase in glomerular filtration rate, and so that's going to cause a decrease in the peripheral vascular resistance. And you might also, I'll just quick review. It's worth mentioning that these congestive heart failure patients, I say they have fluid overload. So how that happens is when the congestive heart failure patient's heart is not able to pump efficiently, blood can back up into the veins that take the blood through the lungs, right? So think the left side of your heart, when there's regurg or when it's backing up, it's ending up back into the lungs if the flow and the travel of blood throughout your body system. So as the pressure in these blood vessels increases, so think right-sided heart failure, it backs up into your, vena cava. Fluid is going to be pushed into the air spaces, or it's going to be pushed into the third spaces, or if it's backing up from the left side of the heart, it's going to be pushed into the air spaces, which are, the alveoli in the lungs, and the fluid reduces normal oxygen movement through the lungs. That's why they're short of breath, right? It's called pulmonary shunting versus, there's something else called physiologic dead space. But pulmonary shunting is essentially where you have perfusion without ventilation, right? So blood flow is adequate, or at least somewhat adequate, but you're not ventilating properly, which is a problem, right? Normal gas exchange is necessary. So physiologic dead space is going to be the flip side of that, where you have ventilation without perfusion, think pulmonary embolism or something like that. And then I spoke about the right side of the heart backing up and regurging. That's going to cause your peripheral edema, your pedal edema, right? It's going to be caused by the backflow and the increased pressure in your vasculature overcoming your baseline colloidal osmotic pressure gradient. Because there's always, a pressure out and a pressure in at a baseline in your vasculature, and when it starts to back up and overcomes the pressure of your baseline, your passive colloidal osmotic pressure gradient, that's when it starts ending up into the spaces where you'll see peripheral edema happen. So they might have ascites, they might have pedal edema, et cetera, et cetera. Side and adverse effects, you look back here to all of these important cations, anions that you excrete. So you need to be careful of dehydration, right? And also, because it acts as an antihypertensive through that previously mentioned mechanism, be careful for hypotension. It's a useful drug. It really is a useful drug. The doses vary, and I said I wouldn't mention doses, but it's just worth noting most EMS systems will administer in the emergent setting the patient's daily dose if they already have a prescription, or start at 40 milligrams. Glucagon, another very useful drug. It's everybody has a different opinion on it. You might see a diabetic have an emergency kit at home, like an EpiPen, to administer this, or have a family member administer it to them in times of when they're unconscious, unresponsive, not able to follow commands, whatever it might be. But we use it for hypoglycemic patients in the absence of that peripheral IV access, right? Because if they're unconscious, unresponsive, not able to follow commands, they can't swallow, you can't have them eat, then you're going to want peripheral IV access to give the D10. But if you can't get that access for whatever the reason might be, this is your alternate option. You can give this intramuscularly. This is a really useful picture to quick review, but it's a good visualization of the negative feedback loop in not just diabetics but humans in general as far as insulin and glucose go. But what this glucagon as a drug is going to do is it's going to increase the plasma glucose levels and cause smooth muscle relaxation, and also an inotropic myocardial effect, right? Because it's going to stimulate the adenylate cyclase to produce CAMP, C-A-M-P, cyclic adenosine monophosphate. That CAMP is more or less going to initiate a series of reactions that's going to lead to the degradation of glycogen to glucose. That's what you want to do, right? Your hepatic stores of glycogen are needed for that glucagon to exert that anti-hypoglycemic effect that you're looking for. So if they're depleted on glycogen stores, this might be not a lost cause, but somewhat inefficient. You might see really small increases in blood glucose levels after administering it and then reassessing, because they need hepatic stores of glycogen. So just think about glycogen, glucagon, and glucose and where they're all located. Glycogen in your hepatic stores, glucagon in your pancreas, and glucose in the blood. But it's worth going over all of this because you want to make a valiant effort to get that peripheral IV access so you can go the dextrose route if need be. But this is a good alternative to have, right? Haloperidol, this is our antipsychotic medication. You'll hear it commonly referred to as Haldol. We use it for its antipsychotic properties. It's written right there in the drug class. We'll use it, alongside of Versed for your agitated and excited delirium, or we might just use it by itself for the antipsychotic properties. What it does is it provides that strong postsynaptic blockade of CNS dopamine receptors, so it's going to inhibit dopamine-mediated effects. Not used often, but super useful to have, especially if you're serving a population where there's a lot of psych patients or mental health disorders. but just be wary of its side and adverse effects. Haldol itself, it can cause those extrapyramidal reactions, and they're scary. Those, if you're not familiar, are your acute dyskinesias, your dystonic reactions, your tardive dyskinesia. Think neuroleptic malignant syndrome. It can cause some pretty nasty adverse effects, or it can have some nasty adverse effects. We are plugging right through here. This is good. Methylprednisolone, also called Solumedrol. You can see a good picture of the vials that we carry here. Somewhat not difficult to use, but if you're unfamiliar with how it is you draw up the medication itself, this orange top right here gets pushed downward, which causes this water in the top part of the vial that's separated by this rubber stopper to drop down into the powder down here, the powdered medication, and that way you can dilute this powdered medication, shake it up, and then it's reconstituted and you can draw it up. And how you draw it up is there's a small circular tab, plastic tab on the top of this vial that you can pop off, and you'll see a rubber stopper right there to draw from. But we use this to decrease swelling and mucus production in airways. It's anti-inflammatory, right? It's a glucocorticoid immunosuppressant. How it works is kind of complex. It takes a while to alter protein synthesis, so the onset can be quite a bit of time. But it suppresses the immune system by decreasing the activity and volume of the lymphatic system, which is then going to produce lymphocytopenia, and it's going to decrease immunoglobulin and complement levels, and decrease the passage of immune complexes through basement membranes. So more often than not, you'll see us using this in our sick respiratory patients where you think there might be mucus production or swelling in the airways. So you can also think about our allergic reaction anaphylaxis patients. Be wary, it can also cause pancreatitis or arrhythmias. Naloxone, Narcan, commonly used medication with the current opioid epidemic going on in a large part of the country. We give this to reverse the effects of most narcotic agents. Think, like I said previously, opiate and opioids. Think heroin, think morphine, think Percocet, think fentanyl, etc., etc. And what it does is it's going to antagonize the opioid effects, which is, think toxicity, think narcotic toxicity. They're going to have that respiratory depression, the sedation, the hypotension. What we're looking to do is reverse that. So Narcan itself provides competitive antagonism of more than one opiate receptor in the CNS. Very useful. There's a lot of studies out there about it causing pulmonary edema. Also be cautious of the fact that after you administer it to a potential overdose or narcotic toxicity, whatever it might be, that the patient also might come to and vomit or feel nauseated and then vomit. And if they're still borderline unconscious, you obviously want to protect their airway. So just be ready to keep their airway clear so that they don't aspirate and get pneumonia later on or whatever it may be. Moving on ondansetron, more often referred to as Zofran. Useful to know that because most people call it Zofran in the pre-hospital environment. And if somebody asks you to grab Zofran and you're looking through the medication kit, nobody would ever guess ondansetron is also called Zofran. So this is our resident antiemetic in our medication kit, and it's also a serotonin receptor antagonist. We use it to prevent nausea and vomiting, and it's thought that Zofran's antiemetic action is mediated mostly via the antagonism of vagal afferents. So, and also, a minor contribution from antagonism of central receptors, but that serotonin receptor antagonist is important, right? Because it's thought that stimulating those vagal afferents via the serotonin receptors is what's going to initiate the vomiting reflex, which we want to avoid. We don't want them to be nauseated. We don't want them to vomit. Be cautious. It may cause QT prolongation, which, I've never personally seen it, but QT prolongation can lead to life-threatening dysrhythmias. You might hear one referred to as torsades de pointe, which is your polymorphic ventricular dysrhythmia. It almost looks like a a wave. It almost looks like not a sine wave, but I'd have to go back and review my physics, but it looks like that polymorphic wave, like VTAC, like a polymorphic VTAC that almost mirrors a wave-like form. Sodium bicarbonate, very useful. It's your alkalinizer, your hydrogen ion buffer. Anybody that has worked, in a hospital, in critical care, in anybody that's even taken, maybe a second year chemistry course has probably heard of HCO3. That's your bicarbonate. If you've looked at basic metabolic panels or ABGs, your arterial blood gases, you've probably seen HCO3 minus levels written on there, and that's your bicarbonate, right? So what we're using sodium bicarbonate for is to treat hyperkalemia, tricyclic antidepressant, overdoses, and metabolic acidosis. Why we use it is because it's going to buffer that acid in the blood, which causes the pH to rise. Your normal, your baseline pH, you want to see humans at 7.35 to 7.45. When your pH drops, you're becoming more acidic, and when it rises, you're becoming more basic, right? So you want them to return to baseline or at least acceptable levels. So you administer this when they have something like metabolic acidosis. It works like any other buffer system to fight the pH changes that are taking place to rise or cause their pH to rise. I'm sorry. So it antagonizes for tricyclic or TCA overdoses, TCA tricyclic antidepressant overdoses. How it works is it antagonizes that sodium channel blockade. And if you use too much of it, it's worth knowing that, bicarbonate in excess of that needed to buffer hydrogen ions can also cause systemic alkalinization. And when it's excreted, it can also cause that, urine alkalinization as well. But if you've looked at basic metabolic panels or ABGs, the HCO3 levels are somewhat comparable. I believe I'd have to refresh, but I think your basic metabolic panel, you're looking for levels of 22 to 28, whereas your ABGs, it's like 21 to 27 or something like that. But all good information to have. You'll see this used a lot for maybe cardiac arrests of patients that had renal disease, or anything that leads you to believe that the patient has severe metabolic acidosis, et cetera, et cetera. And our last medication on the list, we made it to the end, very good, is terbutaline, brethine. Useful medication. You don't see it used very often. It's somewhat new to our system. But it's an adrenergic beta-2 agonist. And what did we review earlier that is also a beta-2 receptor agonist? That is albuterol. So using that, you can probably deduce that this is used to treat symptoms of COPD and asthma, right? Your sick respiratory patients. How it works is it acts directly on the beta-2 adrenergic receptors, and it causes that smooth muscle relaxation, which is what we're looking for. We want to relieve bronchospasm. We want to reduce the airway resistance. This is going to help them breathe better so that they do not become hypoxic. When you use this is, in the absence of peripheral IV access, when you might hang something like magnesium, which we've previously went over for that smooth muscle relaxation, you can give this subcutaneously. So you can start the nebulizer treatment and give this subcutaneously in addition to the albuterol or the duoneb or the ipratropium, some of the previously mentioned drugs that we went over. So this is useful. This is useful to have in your toolkit. And also be wary of the side effects. Make sure you know the side effects of when you administer any medication. And again, thank you so much for watching, and I hope you're able to take something away from this. And if it gains traction, I'm happy to review other concepts in the future or other things in the future that you might want to go over before you start your ride time, your orientation, whatever it might be, at an EMS system. Thanks so much. Take care.